The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss new global classification of brain tumors, improved diagnosis and treatment. My name is Emily Lippert, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce to you our speaker today, Dr. Kenneth Aldape. Dr. Kenneth Aldape is from the Princess Margaret Cancer Center, Toronto General Hospital, and is also the professor of the Department of Pathology at University of Toronto. He is a neuropathologist with an interest in the translational research and molecular approaches towards brain tumor classification. He recently spoke at ABTA's Patient and Family Conference this past July on the World Health Organization reclassification of brain tumors. Thank you for joining us, Dr. Aldape. You may now begin your presentation.
Thanks so much, and thanks to you all for being here. I'd like to talk a little bit today about the update in the classification of brain tumors that has been coordinated with the WHO, the World Health Organization. I'll be presenting some basic concepts as to the need for the classification and some of the key elements that define the update, which we believe is an advance in how we classify brain tumors more accurately to help with precision care. So, the WHO classification for CNS or central nervous system tumors has been updated in 2016. I'll say a few words about the rationale and the need for the update, some of the concepts that define the overall approach that was used, and I will also present some examples that highlight or illustrate some of the changes and the types of changes in the classification. On this slide, we see the cover, the book covers of a variety of World Health Organization classification and updates and classification in brain tumors generally. The first edition on the left was in 1979. That really was the pioneer at codifying how an overall approach toward brain tumor classification. And the WHO is interested in this to help standardize things across the world. This was then followed up by a second edition in 1993, and then in 2000, and also in 2007. More recently, in 2016, as shown on this slide, is the cover of the new update. And as you can see, there's a variety of images on this cover to represent some of the different facets of classification, which include the gross morphology, the imaging, the histology, the immunohistochemistry, and also some of the molecular features that I'll go into for illustrative purposes. So here's a high-level summary of some of the changes in the 2016 WHO classification update. I won't go into all of these in great detail, but really the first point in this table, which says formulating a concept of how CNS tumor diagnoses are structured in the molecular era, is really the overarching principle that was used to help guide this new update. The concept being that as we learn more about the molecular analysis and the molecular features of these tumors, that we are more and more able to incorporate some of these key molecular markers into the already known components of how tumors are classified. And I'll talk to you about that in a little bit of detail as the talk proceeds. So here are some of the key highlights, I would say, in some of these molecular alterations that have been identified. One of them is the concept of co-deletion of chromosomes 1p and 19q, so-called 1p, 19q co-deletion. A second is mutations in the enzyme IDH, or isocitrate dehydrogenase. These two molecular changes have been identified as being of fundamental importance in gliomas, in diffuse gliomas, which include the astrocytomas and oligodendrogliomas. Another mutation in a gene called INI1 has been found to be present in another tumor type, a rare pediatric tumor type called ATRT, or atypical teratoid rhabdoid tumor. Some other features that have been noted in the past 5 to 10 years include the notion of medulloblastoma having specific subtypes. That is, the tumor that on the microscope looks like medulloblastoma can actually represent at least 4 different diseases that can be resolved only through molecular analysis. Similar features occur with another brain tumor type, ependymoma, where molecular analysis shows that tumors that look identical under the microscope nonetheless have differential features based on molecular markers, which may have clinical implications. So going back to the previous edition of the WHO update in 2007, some of these molecular markers are actually mentioned in the text of the book, of the blue book of which the cover I've shown, but they're not actually incorporated into the definition of these tumors. So the major change in the new update in 2016 is that we have reinforced the importance of these markers by putting them into the actual definition of some of these entities, in part to encourage the use of them universally when possible, and also to really help us define on a precision medicine basis these tumors, that some of which can look the same under the microscope but yet have different molecular features and potentially differences in responses to therapy. So moving on, I'll just show you a picture here of a figure that was published almost 100 years ago by a well-known neurosurgeon, Harvey Cushing, and his picture is shown on the upper left. And I think what's interesting about this figure is that how many of the terms are still in use. For example, you'll see on the lower right oligodendroglioma. Again on the lower portion, you'll see ependymoma. Other places talk about astrocytoma, etc. So the point I want to emphasize is that many of the terms that we've used have been around for a long time. They remain very useful. And the new WHO update doesn't replace these terms. It simply adds to them by using adjuncts such as specific biomarkers that have been defined as being clinically relevant based on studies over the past 5 to 10 or 20 years. Okay, and so I'll just provide an example of that change from 2007 to 2016 by showing this definition here. This is direct from the 2007 WHO classification, which every entity in the WHO has a definition. And that definition is usually 1 to 2 sentences that really, to the best of our ability, defines the key elements of each of the entities. So in this particular example, this is oligodendroglioma. And so the definition of oligodendroglioma, as you can read, really is based on where it's located, what kind of patients it's seen in this case, adults. And then it talks about the morphology. It's composed of neoplastic cells morphologically resembling oligodendroglia. You'll notice that after that, it says, and often harboring deletions of chromosomal arms 1p and 19q. So there's a subtle issue here, which is that the concept in 2007, what is that oligodendroglioma is defined based on how it looks under the microscope. And you can see a picture of oligodendroglioma on the left. And the concept here is that it is associated with 1p19q codeletion. In the the concept here is really that the 1p19q codeletion is associated with oligodendroglioma in 2007, but it's not defined by that molecular marker. And here I'll just show you one of the ways we can actually test for 1p19q codeletion in tumors. And that's using a molecular method called FISH, or fluorescence in situ hybridization. Here you can see an example of, on panel A, of a FISH result showing in many of the cells 2 red dots but only 1 green dot, which indicates deletion of one arm of the chromosome associated with 1p19q codeletion. One reason why we would want to help use molecular markers in helping to define entities is that morphology, that is the study of how the tumor looks under the microscope, although it can get us far, it is the standard practice among pathologists to classify tumors. It is at some level subjective. That is, there are specific cases that may have intermediate features or features that are difficult to discern. And because of that, there can be diagnostic discordance in certain kinds of tumors. And I just present some quotes here from pathologists who have noted this, that there are some tumors, for example, that are difficult to classify in either group, as the quote says above and below. A paper from Dr. Kunz in 1997 shows that looking at grade 2 and grade 3 diffuse gliomas, that the concordance rate among neuropathologists may not be as good as we hope. So based on the fact that there can be some subjectivity in morphologic diagnosis, there is a need then to use molecular features to help close that gap so that we can increase the concordance and increase the standardization of how we classify these tumors. So that's really the point that I wanted to make on this slide, that is that molecular markers can improve inter-observer concordance and improve the standardization of classification. As I've mentioned, there are many morphologic features that do have a basis in biological findings. For example, oligodendroglioma is often associated with 1p19q codeletion, and therefore it makes sense to connect those two. It makes sense to connect the morphology of oligodendroglioma with the codeletion of 1p19q codeletion. Interestingly, there are some additional markers that don't have such a relationship to morphology, but even so, they can elucidate clinically relevant distinctions within an entity. And in that particular example, and we'll talk about that a little bit, and that is IDH mutation status. Lower grade gliomas, grade 2 and grade 3 diffuse gliomas, can have either the presence or the absence of IDH mutation status. Although they look similar under the microscope, the fundamental nature of IDH mutation in determining biology is so important clinically that it was felt by the consensus of neuropathologists involved in the WHO classification, of which I was one, that IDH mutation status should be included in a definition to really separate those tumors that are IDH mutant from those tumors that are not. And that being said, it's also true that new technologies in genomics may also establish the relevance of key markers in brain tumors in the future. In other words, it's possible that markers under investigation today, once we gain more experience with them, and if clinical relevance is shown, could be incorporated in a future update of the WHO classification. I'll just show you an example of how, and I won't go into great detail, but just an example of how some molecular analyses have been used to really justify the fundamental importance, for example, of IDH mutation and 1p19q codeletion, really in the classification of gliomas. Again, I won't go into great detail, but here is some data from a national and international initiative called TCGA, Cancer Genome Atlas, which was an NIH-funded and sponsored study, which put together a number of different molecular platforms. I won't go into great detail on each of these platforms. I've listed them here for your interest, but the bottom line is that for about 280 or 290 tumors of lower grade glioma, that in most of these tumors, they were profiled using many of these platforms, and an integrated analysis was performed on 254 tumors from this group. And the major question being asked is, if we can integrate all these things together, what's it telling us about some molecular markers that we're using? What is the relevance of these molecular markers? And again, I won't go into great detail here in this slide, showing a high-level genomic analysis, but the major concept is that three major subtypes, and you can see them here on a so-called clustering analysis, where you can see a group here, and a group here. And these groups, by and large, corresponded to the presence or absence of IDH mutation on the one hand, and also the presence or absence of 1p19q codeletion, the so-called codel versus non-codel groups. And that information is summarized here, starting with, as I mentioned, about 280 tumors, grade 2 and grade 3 lower grade gliomas. The first cut, the first separation between these tumors, in fact, was not how they looked under the microscope. It was not whether they were, for example, astrocytoma or oligodendroglioma. The first major cut was whether or not they had an IDH mutation or not, the so-called IDH wild type being not mutated, and these tumors being mutated for IDH. As a second cut, if the tumors were IDH mutant, a second cut could be seen in the genomic analyses, and that is whether or not they had, as I mentioned, codeletion of 1p19q or no codeletion of 1p19q. So this gives us really three major subgroups of diffuse lower grade gliomas, and this publication by the TCGA, the Cancer Genome Atlas, was published a little over a year ago in the New England Journal. I'll just point out a couple things here, and that is that the IDH wild type tumors, which are a minority of the lower grade gliomas, nonetheless can at times have some of the molecular features suggestive of higher grade gliomas, such as glioblastoma. And as we talked about, the tumors that are IDH mutant but codelated for 1p19q, these are associated with oligodendroglioma, and the ones where codeletion is absent are associated with astrocytoma. Another point, I think, that was a finding from these studies, and as well as other studies, is that the entity that neuropathologists know as mixed oligoastrocytoma, that is a tumor that has features intermediate between oligodendroglioma and astrocytoma, actually had no molecular correlate. In other words, tumors that were profiled by TCGA with the diagnosis of oligoastrocytoma had no distinctive molecular feature that distinguished them from either oligodendroglioma or astrocytoma. And based on that result, there's been a movement here, and I've just illustrated a recent paper that provides a sort of statement to that effect, a farewell to oligoastrocytoma, really indicative of the fact that this particular morphology doesn't really have a molecular basis, and therefore it's actually been de-emphasized in the WHO 2016 update, in large part based on this finding. So this really leads us to a question that was put to the panel that decided how to actually update the WHO in 2016. That's really the overall question of how and when do we incorporate new molecular findings into the classification. New findings in gliomas and other tumors, such as medulloblastoma and ependymoma, occur almost on a weekly or monthly basis in the literature. And that makes it both very interesting, but also it adds to the questions, when is it practical to actually incorporate that molecular finding into a WHO definition? So balanced with the need to incorporate new data is the companion need to maintain a consistency and a standardization. One needs to sort of have a stopping point where one can actually incorporate changes so that it can be accepted and studied by the community. And equally important is whether or not the molecular changes that are being found in the laboratory are clinically relevant, because the classification is above all for something that is to be used clinically and is important to that it be relevant clinically. And there's also a need, again, to ensure that the classification system is accessible and workable to all. So the molecular markers that are proposed really should be something that could be generalized across centers. So we began this process in the summer of 2014, and as I showed you, ended up with the publication in 2016. On this slide, I just point out that some of the things I've already discussed, which is that entities really need to define as specifically and as narrowly as possible to really optimize the inter-observer reproducibility. We don't want entities that are hard to reproduce across centers or across pathologists. We want to minimize diagnostic discordance so that things are standardized. Another concept that has been really emphasized is what we call the layering of a diagnosis. That is, incorporating the fact that not only is there morphologic data under the microscope, but there's molecular data too. So we can layer these different kinds of information into a diagnostic report and integrate them. As we talked about, the determinations really should be made for each tumor entity as to whether molecular information is required or is really not quite ready for prime time. So maybe it should be suggested but not needed for its definition. Some of the other features in the 2016 update for the WHO is that in many cases there are tumors that occur in children in the pediatric age group that, although they look similar under the microscope to tumors that occur in adults, really have a very different molecular background or molecular basis. Oligodendroglioma is one example. Oligodendrogliomas that occur in children do not have the 1p19q co-deletion that we've talked about. They don't have the IDH mutation either. So even though they look very similar under the microscope to the adult oligodendroglioma, they're not the same molecularly. And since tumors behave in large part according to the genes that are altered in those tumors, it was felt that in many cases pediatric tumors should be separated in some way from their adult counterparts so that we don't lump things together that biologically are not similar. Other features that I think were important in the WHO's 2016 classification was that it was codified by a group not only of pathologists but by other experts in related disciplines such as medical neuro-oncologists, neurologists, neurosurgeons, etc. So this was done to really help ensure the clinical relevance and clinical translation of some of these changes that were proposed. And as I mentioned, there is a need then to really incorporate this molecular testing and use reporting formats that are compatible with both the use of morphology and molecular analysis. So here's an example of of the so-called layered diagnosis or layered diagnostic format that could be used. In fact, we are using at our institution to integrate and really incorporate all the information that's relevant into a tumor classification. Typically, when a pathologist receives a case, the initial material will be, in fact, be slides, histologic slides. Sections are cut from a tumor. Those sections are stained with so-called H&E, hematoxylin and eosin. And based on that, an initial histologic classification is made. For example, astrocytoma or oligodendroglioma. That's the cell type, for example. And then a grade is also assigned. Grade 1, grade 2, or grade 3, or grade 4, etc., which I think reflects natural history or the clinical potential clinical behavior of that entity. So this is sort of the tried and true method of classification. But added to these layers are now relevant molecular information. And then once all the molecular information is obtained on a particular sample, that can now be integrated into the first layer, the integrated diagnosis, which incorporates all the tissue-based data, the histologic classification, the grade, and the molecular information. So here are just some examples of some potential integrated diagnoses of medulloblastoma. As we'll see later, that there are now some subtypes of medulloblastoma. They are listed here, either the Wnt subtype, the SHH or sonic hedgehog, or the non-Wnt, non-sonic hedgehog, etc. Histological classification, there are a variety of histologic variants of medulloblastoma, and those are shown here. The WHO grade or grade 4 is present, and then these are just some examples of potential molecular information that can be present. So the concept of the layered diagnosis really goes along with the incorporation of molecular analysis added to morphology to come up with an integrated diagnosis. Okay, so in this particular slide, we talk about whether the molecular marker actually defines that entity or is it in fact highly correlated with that entity. And it really brings up questions is what do we do when the testing for the marker is not available, but we still need to make a diagnosis. For example, we talked about oligodendroglioma. There may be cases where the tissue is too small to really do a 1p19q test, or the 1p19q test may not be available at the particular center. A variety of things can happen. And so the WHO really needs to make sure that we can still have a way to classify these tumors, because the WHO is really meant to be worldwide. A second issue is what to do when the molecular marker result is in some level at odds with the histologic entity. We've talked about 1p19q being highly correlated with oligodendroglioma. What happens if there's a tumor that by all rights looks like an oligodendroglioma, but is not 1p19q co-deleted? For example, a pediatric oligodendroglioma, as we talked about. So we need to have a way to put these things that don't quite fit still into a diagnostic category. So here's some examples of how some of these issues were dealt with. In this particular example, the pediatric tumor ATRT, or atypical teratoid rhabdoid tumor, it was felt that it is so ingrained with a particular mutation or set of mutations, either INI1 or BRG1, that either one of these mutations had to be present to make the diagnosis. And here's an example of a layered diagnosis for a patient with atypical teratoid rhabdoid tumor, where the INI1, in fact, was mutated. So ATRT is an example of a tumor that is defined by a molecular marker. So that's why I say up here, no marker, no entity. So the concept of ATRT is that if it has the marker, i.e. INI1 or BRG1, then it can be called ATRT. But what if it doesn't? What if it's a tumor that looks like ATRT but does not have either one of these changes? And it was felt that in that instance that we would back off from a specific diagnosis, and we might give it a diagnosis such as shown here. For example, embryonal tumor with rhabdoid features, that it looks like a rhabdoid tumor, but it doesn't have the molecular analysis required of an ATRT. So this would be an example of how we would deal with a situation of an ATRT, or something that looks like an ATRT but doesn't have the required molecular change, either because it was tested and wasn't present, or because for whatever reason it wasn't tested. Then we talked about other examples, for example, oligodendroglioma, where 1p19q testing is highly recommended for tumors that look like oligodendroglioma. But one can imagine three scenarios with a tumor that looks like an oligodendroglioma. 1p19q testing could be performed and it would be found to be co-deleted. 1p19q testing could be performed but it's found not to be co-deleted, or for whatever reason, 1p19q testing might not be performed in that particular example for a variety of reasons, as we've discussed. So we need to have ways to make a diagnosis no matter what scenario is happening with a particular case. And so here's an example of a co-deleted oligodendroglioma where this would be the classification where it's present. But what about if it's not present? We might back off and give it a diagnosis of diffuse glioma, comma, or parentheses, oligodendroglioma phenotype, but 1p19q non-co-deleted. And then finally, another proposed way of dealing with this is the so-called NOS category, not otherwise specified, where if this tumor, for example, did not get 1p19q tested, but yet looked like an oligodendroglioma, then there is a classification in the WHO, the so-called NOS category, for that entity. And here is some of the possible scenarios. I won't go into all of these scenarios, but where the histology and the molecular, where we know there are some good correlates. Here on the upper left is the diffuse astrocytoma, which is known to be commonly mutated for IDH. That's why it says IDH mutant. It's usually not co-deleted for 1p19q, so that's why we have 1p19q non-deleted. And it's usually lost for another gene that we haven't talked about, ATRX. So here's an example of like an astrocytoma. It has the associated molecular abnormalities, and so it would be easily classified. Here on the right are we talked about the oligodendroglioma 1p19q co-deleted tumors. But then, of course, we need to have all of these other possibilities for tumors that look like either astrocytoma or oligodendroglioma, but yet have some of these other possibilities. And so, again, I won't go into detail, but here are some proposed ways to classify these tumors. And again, on the lower panels, we've talked about the NOS concept, where the testing isn't performed, but yet pathologists can still classify these tumors as diffuse astrocytoma NOS or oligodendroglioma NOS. Okay, and so I'm going to go over just some of the next few slides relatively quickly to make sure that we cover everything. But the concept here is that what are the standards for testing? The WHO, to keep it succinct, cannot mandate standards for testing. So specific ways things are tested can be different. However, the job of the WHO is really just to provide an overall guide for how these tumors are to be classified. I'll just illustrate an example here on how we use some of these markers in daily practice. It turns out that IDH1, when it's mutated, the most common mutation occurs on codon 132, and that change changes an amino acid on codon 132 from R to H, arginine to histidine. So the so-called R132H mutation in IDH. It turns out that we've made a marker, an antibody marker, that sees this mutant IDH. It doesn't see the wild type it doesn't see the non-mutant, it only sees the mutant. And this is a very helpful diagnostic tool. Here you can see a tumor on the left that is positive for the mutant IDH antibody, really indicating there is the mutation present. Here you can see on the right a section of brain with only rare infiltrating cells that are positive for IDH. In here, it just really reinforces that concept that most IDH mutations occur in IDH1, and most of them are R132H. Not all of them are, and so many of us, for the 10 to 15% of cases that are not antibody positive, that is negative here, we will then go on to sequence to rule out a so-called non-canonical IDH mutation. We've talked here again about 1p19q testing, which can be done by FISH, as we've mentioned. And here are really the possibilities of 1p19q and IDH testing. We have 2 markers and 2 results. And so that gives you 4 possibilities, although practically speaking, the possibility here on the right doesn't occur. And so here are some of the ways we can think about these tumors in the diffuse glioma category. Okay, we've talked a little bit about medulloblastoma, a tumor of childhood that has an appearance on the microscope. It's a so-called small round blue cell tumor. It's been found that by molecular analysis, there are at least 4 groups of these tumors, and they're codified here, the so-called Wnt group, the SHH or sonic hedgehog group, group 3, and group 4, based on molecular analyses. And I won't go into detail, but this just sort of provides some rationale for why we might want to subtype these into 4. The Wnt, sonic hedgehog group 3, and group 4. Here are some of the common molecular changes that are associated with each of these groups. And here's some additional data which really, I think, again, I won't go into detail, but provide some justification for why one would want to separate medulloblastoma into one of these subgroups based on the clinical behavior. It gets even more detailed as more data is obtained and more questions are asked. Things become even more complicated, as usually happens in science. Here in this paper, not only have they subdivided medulloblastomas, they've only looked at one group, the sonic hedgehog group, the SHH group, and they found that based on a subset of sonic hedgehog tumors, some of them have p53 mutations, some don't, and showing that p53 mutations can affect the response to targeted drugs, such as a drug against a gene called smoothened. Again, I won't go into great detail, but just to give you a flavor that more and more we're finding additional ways to classify these tumors. And so this really just reemphasizes that p53 mutations may be important in these tumors. With ependymoma, ependymoma is another type of tumor in the brain that may come from the ependymal lining of the ventricles of the brain. Here's some histologic pictures of ependymoma, and although histologically many of these can look the same, it's very clear that they have different features. I've shown here on this slide show the 3 major compartments: the spinal cord, so-called supratentorial, which is the cerebrum, and then the posterior fossa or the cerebellum or brainstem. That some features can differ, even though they look similar in the microscope. Some of the clinical features can differ based on the location. And here's an example of that, where in this particular paper, they divided ependymomas into cerebral or supratentorial versus those in posterior fossa, and you can see here that that this particular marker of a fusion, so-called C11ORF95 to RELA, a fusion of 2 genes, is really present only in this compartment, only in the supratentorial tumors, but not in the posterior fossa tumors. again showing the relationship of the location with the molecular lesion. So even though these tumors can look similar under the microscope, it's clear that the molecular basis of these tumors can differ. And so based on that, the WHO has now a defined entity of C11orf95 RELA fused ependymomas that occur in the cerebrum or the supratentorial compartment. In the posterior fossa, in these tumors here, it's been very recently found that they can have changes in the epigenome or epigenomic changes, and that it's possible in the future that that will then be incorporated into a WHO update, perhaps in the future. And this really is a high-level view of some of these epigenomic changes showing that they may define differences in types of ependymoma. Okay, and this is just sort of finishing up to review. So here is some of the entities that are now in the new WHO classification. In the old 2007, we just had glioblastoma. Now we have 3 flavors. We have glioblastoma IDH1 type, glioblastoma IDH mutant, or glioblastoma NOS. That is, IDH status is not fully known. The astrocytomas and oligodendrogliomas we've already talked about. We can have mutant, wild type, and then we, as we talked about, where the testing is not known, we have the NOS designation. We've talked about ependymoma, where we've now incorporated this new fusion, this REL-A fusion that is now in the supratentorial tumors. And then we've talked about medulloblastoma, where it's now defined both on the genetic basis, these 4 subgroups that we've talked about, Wnt, sonic hedgehog, group 3 or group 4, and it also can be classified based on how it looks under the microscope. And then the final diagnosis is really a integration of these 2 kinds of data. So some people have asked me and other pathologists as to whether molecular analysis will render morphology irrelevant. And I think the answer to that is no, that molecular analysis will help fill in some gaps, but morphology still has a very important role, and the way a pathologist classifies a tumor in the microscope is still very important. And here is some Kaplan-Meier curves of patients based on morphology alone, showing a great effect of morphology. So morphologic diagnosis still has a very important role, and what we're doing is we're trying to supplement that with molecular analysis, just to help us. For example, to help this gap here as to this group of patients, for example, with anaplastic astrocytoma that have lived a very long time. How do they differ from patients with plastic astrocytoma that have a much poorer prognosis? So where the molecular analysis will help, and I think in the future, is the so-called within histology outcome variation. And that is, how can we even more precisely define these tumors in addition to morphology? And I won't go into great detail, but we have conducted a survey of experts in the field by surveying the largest society of, in our field, the so-called Society of Neuro-Oncology, or SNO. And we asked them their enthusiasm about incorporation of molecular changes, and it was reassuring that the answer was yes. Here's a breakdown of the specialties, which included a variety of specialties: neurosurgery, neuro-oncology, neuropathology, etc. And here, in this particular question, do you think our knowledge of molecular classification is at a level where it can be integrated into WHO classification? And you can see here that the vast majority, over 80% of respondents, felt that the answer was yes. So this was very reassuring and really supports some of the changes in the WHO. So just to finish up and summarize, the WHO update for CNS has been done in 2016, and here I say it's in process because it's not a static thing. That there was a 2016 update, but changes occur daily, and more updates will be happening and will be needed in the future. as we try to get to this goal of individualized or precision medicine. The goal is to introduce clinically relevant molecular markers that are an adjunct to morphology. But doing that, we also need to accommodate, have a classification system where the molecular tests don't work, or it's not available, or the tissue is not sufficient, etc. So we almost, in some level, have a two-tiered system, something that's morphology alone, and something that, in an ideal case, includes the morphology and the molecular. And so the concept really is to really interact with our colleagues and our patients to ensure that the updates and changes we make are clinically meaningful and important. So with that, I will thank you for your attention, and I'll be happy to go further with any questions that may come up. Thank you.
Thank you, Dr. Aldape. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. All right. A first question that we have is, can tumors be classified without a biopsy?
The answer is, by WHO, the answer is no. That a tumor to be classified really requires a tissue sample. That is either a biopsy or resection, some sample of a tumor to be examined by a pathologist. Now, there are circumstances clinically where a biopsy may be not indicated for a variety of reasons, based on the location of the tumor, the condition of the patient, etc. So there are some cases where a biopsy is may not be performed for some of these reasons, and a diagnosis may be presumed based on likelihood based on the clinical features or the imaging. So the short answer is no, it cannot be formally classified. The more complex answer is that there are rare cases where a biopsy is not performed, and there's a presumed diagnosis based on the clinical features.
Thank you, Dr. Aldape. Our next question asks, how have prognoses improved in brain tumor patients with the new WHO grade classification system?
I think what we can say is that the predicted prognosis of patients with the new WHO can be more accurately refined. And I'll give you an example of that. And that is that in gliomas, we've talked about the two main types of gliomas on a molecular level. That is, those that are IDH mutant and those that are not IDH mutant. It turns out that IDH mutant gliomas, those patients have a better prognosis than patients, on average, than patients whose tumors are not IDH mutated. So while the classification itself doesn't improve the prognosis, it improves the stratification of patients into more refined prognostic groups. A second example is that some of the molecular markers are actually predictive. That is, they help predict response to a particular therapy. 1p19q codeletion is a predictive marker for response to alkylating chemotherapy, either PCV or temozolomide. So the use of 1p19q can help determine the appropriateness of alkylating chemotherapy for patients. And so in that way, it could then refine the class of patients that will get the most benefit from that particular therapy. So it's that precision medicine, the precision oncology approach that I think is most of the benefit of the molecular analysis in the new WHO.
Thank you. Our next question asks, are there specific genetic test names that need to be done to get its conclusive profile of molecular biomarkers for different tumor types? And then it also asks, what type of genetic labs are qualified to test?
Many hospitals, most hospitals have the capability to do many of the tests that I've talked about in this presentation, in particular IDH mutation and 1p19q testing. So we've talked about how 1p19q can be tested using the FISH method, the fluorescence in situ hybridization of FISH. That is the one most commonly used. There are other methods as well that can be equally as good. Again, the WHO can't dictate what method that is used, but every hospital that does pathologic analysis, and that's every hospital, really has a certain set of standards that it must fulfill to do clinical tests. And so it's within that hospital usually been shown to be an excellent test. So the particular test can change the way it's done, but the hospital, particular hospital, usually has the method to do it. There are other tests that I've shown you that may not be as widespread, that are, I would say, in between the research and the widespread clinical use. We hope that with the WHO 2016 update that it encourages people to incorporate many of these tests, and I would encourage patients who have specific questions to contact their physician about the relevance of a particular test, and if so, how that might be done in an individual case.
This next question directly ties to the previous question as well and asks, how do I approach my healthcare team if I would like to get molecular testing done on my tumor? And what are some good questions to ask them?
Yeah, I think that's a great question, where it's important to know that there are some tumors where it's felt by the WHO and by the clinical community that molecular analysis is very important. We've obviously talked about 1p19q and IDH for diffuse gliomas, etc. There are other tumors where we may not yet have a molecular test that's clinically relevant. So the importance of molecular testing is really highly dependent on the particular type of tumor that we're talking about. So I would encourage patients and their caregivers to communicate with their healthcare providers, trying to ask that particular question. Are there clinical molecular tests that would be relevant to that particular tumor type, so that that it can be performed if clinically relevant? That is to say, it may not be relevant for a particular tumor type that one might have, but there may be another tumor type where it is highly relevant. So I would definitely encourage that conversation to occur, to really ensure that each tumor is being diagnosed and classified appropriately.
Thank you. Our next question asks, can old pathology reports be used to determine a tumor's classification according to the new WHO classification system?
Yeah, that is a good question, and it for the most part, the answer obviously depends. It depends on a case-by-case basis what's in that pathology report. But for example, if a pathology report has a specific tumor type, such as astrocytoma, and then somewhere in the report it talks about what the IDH status is, then that can easily be then reformulated into the new integrated diagnosis that we talked about. It really depends on the individual pathology report as to whether it can be directly translated into the new classification. So it would really depend on what's in that pathology report, whether the relevant molecular analysis is performed. But assuming that it is, then yes, then one should be able to translate the old information into the new WHO 2016 classification.
Thank you. Our last question asks, do you go back and test again after recurrence of a tumor? And is it necessary to test all tumor locations in a multifocal tumor?
Those are two very, very good questions. The answer is that we will often retest the tumor if there's a question as to what might have happened in the interval between the initial procedure and the follow-up procedure to really confirm that there's not been a change. We do believe that for the most part, some of the markers that we test for are on average fairly stable. It's not 100%, but for the most part, some of the markers such as IDH mutation or 1p19q codeletion are stable. And so there may be instances where it doesn't need to be retested at recurrence. However, if there's at all a question based on the clinical features, on how it looks under the microscope, then that repeat testing can be done and could be considered on a case-by-case basis. So the answer is it's a mix. Sometimes we do retest to confirm, sometimes we don't. It really depends on the individual circumstance. And the other question about a multifocal tumor is also a very active area of study right now, the so-called intratumoral heterogeneity, how the molecular features of a tumor might differ based on the location. What we're finding is some of the major markers that we've talked about, again, are very stable and don't vary among different sites of the tumor. However, there are some secondary changes, some other mutations that may differ based on the location. And that is not ready for clinical use, but that's really an area of active investigation that I hope can really elucidate more about how tumors change across the brain.
That is all the time we have for today. Thank you all for joining us, and thanks once again to Dr. Aldape for his wonderful presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, visit ABTA's website at www.abta.org or call the ABTA Care Line, which is staffed by caring professionals at 1-800-886-2282. Let's pause for just a moment to conclude our webinar recording.